about 6 weeks ago, and it was pretty well received, and I put a fair bit of time into it, and I noticed that there was only maybe, I don't know, 6 people from Agnesian that was there, so I thought, let's just do it here and torture everybody here a little bit. So we're gonna do it again. Was anybody at the symposium 6 weeks ago? Jen, I recognize you. I hope you haven't given any of the
It's all
secrets
new.
away.
It's all new. It's all new.
All right. Well, some of the pictures have been changed, actually. Some of the pictures that I took were at another hospital that we cover. It was one of the days that we had one of those nasty snowstorms. It was really slow, and so we took a bunch of pictures around the department. But I updated that to include some more pictures from people here at St. Agnes, so you will be recognizing some people. You're going to see a picture, a side of me that you didn't know existed. Your face is going to look like this baby at the end of the talk. I suppose actually I could start showing a couple of pictures here. At the symposium, wait a second, I don't know if we want to start this or not because I'm going to stop until the pizza comes, but I'll show a few pictures. Yes. I don't know.
Is Rafan ripping? Are they able to?
Yeah, they're watching.
They're on the computer now.
Okay, we started.
I do have one, by the way.
So at the symposium, the way each talk was started was the radiologist was asked a few questions, kind of like the newsletter that Jody puts out, some personal questions and some pictures. And one of the questions that I was asked, we've just jumped back 5 minutes. Are you able to hear me? Yeah. Is it coming through the mic? I can't tell. Yeah. Okay. So one of the questions that was posed is, what's something about you that nobody would guess? And my answer to that question is I'm actually building a supercar in my garage. And I've been working on that for the past year and a half or so. I think I started in November of 2016. So I tortured everybody with a few pictures of my project. And since you are a captive audience, you will be tortured as well. So basically, this is what it started with. It's a kit car made by an outfit called Factory 5 Racing. And this is basically what I started with a whole bunch of boxes of parts and pieces. So it's just a welded frame that's black powder coated. And here's a picture several months into the project when I'm wiring things, and it gets pretty complicated. And actually, last night I was working on it, trying to install the windshield wiper and the linkage, and it's starting to bleed again. I scraped my finger across the metal, and that's been kind of the story with this car. Nothing is easy and straightforward, and it's been a challenge every step of the way. But this is called the go-kart stage, and it was a blast driving this thing down the road like this. It's very, very light, and it's got a huge engine in the back, so the thing really screams.
That's legal?
Believe it or not, it is.
It is.
And I didn't know if I would be able to get it licensed or not, but it's licensed as a hobby car, and it had to be a replica of a car that's at least 20 or 25 years old or older. And it looks very, very similar to something called a Ford GT40. And so I used that as saying it was a copy of that car, and they put it through. So I actually do have plates.
Try that to work.
Yeah, well, having never done anything like this before and not being super mechanically oriented, I don't know if you'd want to trust me to get in here on time. But I just got it back about a week or so ago from the paint guy, and it still has a lot of work to do on it, but yeah, it's been a lot of fun. And my dad, who's 87 years old, has had a blast helping me with this car. He's just been in it full board. So it's been an incredible project, a lot of fun. lot of frustrations, a lot of Band-Aid usage. But,
You have a very clean garage.
why, thank you. Could you mention that to my wife? All right. I think I'm going to have to torment the pizza guy when he gets here.
Okay, how fast is that truck?
It's actually supposed to go just under 200 miles an hour. They clocked one of them just over 200 miles an hour recently. It has a high-performance GE or GM trade engine in the back that goes with the Corvettes.
What's the motor horsepower?
It's an LS3 crate engine, and the rated horsepower is 430, but it's got custom exhaust in the back, which you can see here, and that actually decreases the back pressure, so it adds like 30 horse to it. So, and the car only weighs 2,500 pounds, so it's going to be dangerous. Well, guys, I don't know what to do. I guess I can get started and just stop when the pizza gets here, and we can continue as everyone gets stuff. I don't know, what do you think?
Sure.
All right. Okay, so the title of my talk is Job Number One. Now, what in your minds is job number one? You guys working in the radiology department, what do you think is job number one? Safety, no, that is a very, very good guess, but that is not your job number one. Job number one is making the radiologist happy. There's no other job that is more important than this. Your first priority is to make the radiologist happy. What makes the radiologist happy? And by the way, this is a sneak peek at the new reading room chairs that we're going to include. SSM has been very generous and accommodating. Dr. Douglas is unhappy that it doesn't have any cup holders, but we're working on that. But this is going to be the picture here pretty soon. If the radiologist ain't happy, ain't nobody happy. You guys know that. And what does the radiology want? He wants safety. So that means safety is job number two. Okay, and I know what you're thinking. You're thinking, holy smokes, talk about safety. We only have an hour, actually now only 50 minutes thanks to Pizza Hut, but this could go on forever. We could cover a million things. So I'm going to put your minds at ease, and I'm going to let you know things that we are not going to be talking about, so you won't be too worried. We are not going to be talking about safe drinking responsibly. This is my beverage of choice. I have a bottle up here right with me. We are not going to be talking about idiots pulling prank fire alarms, which I will not confess to, but happens on occasion. We're not going to be talking about that. We will not be talking about diabolical CT techs irradiating innocent passers-by. And I don't want to be too hard on Tara. I mean, I don't want to judge character, but look at the face. Some innocent person is in here being irradiated, and she's laughing. We're not going to be talking about that. We will not be talking about accidental nuclear medicine dosing errors. Dan lived to tell about this. We won't be talking about crazy risk-taking on wet hallway floors. We won't be talking about safe defibrillation techniques. This is one of our ultrasound techs, actually, at one of our other hospitals. We will not be talking about safe compression levels for male mandarins. Now, I don't want to put words into Jenny's mouth, but I think she said something along the lines of she had never seen a human withstand this level of compression. So, enough of this stuff of, oh, you don't know what it feels like. And I know you're all wondering, so I'll just answer the question right now. Yes, I do work out regularly. Okay, we're not going to be talking about the safe handling of biopsy needles while telling fascinating stories about building kit cars. And here is what we will be talking about, stuff like this, safety, like with metal in the MRI. And this picture was taken at one of our other facilities that we cover, and just to set the picture here for you guys. So we did multiple takes on this, and there's a group of people outside the view of the camera that are sitting there laughing away, and so I've got this oxygen tank, like I'm going into the room, joking around, laughing, and right at this point when the picture's being snapped, the door opens up and the patient comes out with a heart attack. So we're all like, woo! So it was a challenge getting these pictures, but I will do anything for you, as you know. Okay, so fasten your seatbelts. We're going to spend a little bit of time talking about safety as it relates to the radiology department. We're just going to cover a few things here. Correct patient ID, radiation and contrast safety, good communication as it relates to safety, and a little bit on MR safety. So we're going to start out talking about identifying patients and timeouts. Now, timeouts and site markings, what a big pain in the butt. Big waste of time, right? I know some of you have heard me say this, and on occasion I do, because when I'm involved with stuff like this, usually it's because I'm doing a breast biopsy, and if I can't see the lesion, I can't do the biopsy. So it makes no sense for me to be going through all this stuff to identify the site. So, you know, I've been a big poo-pooer of this stuff, but I know when to admit when I'm wrong, and I think I am wrong, and we're going to talk about this a little bit. So back in 1995, anybody here born after 1995? Okay, well, at least you're all these born then. I was thinking, boy, you know, that doesn't seem that long ago, but that actually was a long time. Well, in 1995, the wrong leg was amputated from a guy. And, you know, when you hear that story, you think, holy cow, how in the world could somebody actually amputate the wrong leg? And the next picture is going to be just perfect for eating pizza with. So I'll wait here. We've got Pizza Hut has finally shown up. Hey, thanks, guys. So we'll put a stop to this, grab some pizza, and I'll continue once you get your plates going.
What hospital makes you wear scrubs?
Actually, yeah.
You were next year.
Yeah, I do wear scrubs in one of the hospitals. I do more procedures there. I like coming to work in jeans. Picking up where I left off. So the wrong leg was amputated from a guy, and you would think this is insane. How in the world could somebody possibly amputate the wrong leg from somebody? Well, which foot would you take? This isn't the picture from that specific scenario, but it was something like this, where the person had bad infections, gangrene, osteomyelitis, and they had to take one of the legs off, and the other one was probably going to be coming off shortly. So it wasn't like, you know, a normal, healthy leg and one that was terrible. I mean, egregious enough, granted, but it wasn't as bad as you would think from what the media says. But once that happened, there's no turning back. And basically in the mid-90s, there were multiple specialty societies that started getting their own safety measures. But it wasn't until 2003 that JACO actually started what they call universal protocols to end never events. And basically those are events that should never ever happen. So what's the big deal? So basically, from 1990 to 2010, just under 10,000 paid malpractice settlements and judgments for surgical never events occurred. So that's a big number. The malpractice payments for surgical never events totaled about $1.3 billion. I mean, you're getting up close to a radiologist salary when you're talking about. Mortality was around 6.5%, permanent injury 33%, temporary injury 60%, so significant numbers with this stuff. The estimated 4,000 surgical never event claims occur each year in the United States. And that's based on malpractice payments. So there's even a lot more than that that's happening that never even gets that far to malpractice payments. So this stuff is happening. And in researching this, the thing that stood out to me and amazed me that of the physicians that are named in these surgical never event claims, 12.4% of them were later claimed in a future surgical never event. I mean, wouldn't you think that once you cut someone's leg off wrong, you'd be thinking, I am never doing that again. So 12% actually do the same thing again. This was in the media just a couple months ago. Kenya doctors perform brain surgery on the wrong patient. Now, when you go in for a flu shot, you don't want to wake up in recovery after a craniotomy. So this stuff is still happening. This wasn't in the US, but holy smokes. I noticed all of this stuff was surgical. Radiologists aren't the idiot culprits, right? Well, maybe, maybe not. So look at the image here. We have a 19-year-old trauma patient who came in, had a portable chest x-ray. So what do you see? And basically he's got a big pneumothorax there that's going to need a chest tube right away. So I call up the ER, slam a chest tube in the right side. What do you think? Can't hear you. It's mismarked. The marker's on the right side instead of the left side. So this kind of stuff happens and mistakes happen and it's not good. You know we love you guys, but most of the errors in radiology are related to the wrong patient and wrong exam or mismarked studies. A study at a tertiary care pediatric hospital showed that basically they were having wrong patient, wrong study occurrences about once a month. And the Pennsylvania Patient Safety Authority in 2009 did a study, and they found 652 errors, so that's during the year. 30% were characterized as wrong patient occurrences. So you're saying, okay, so what, big deal, no one's foot was cut off. I mean, marker on the wrong side, no harm, no foul. Well, sometimes there is harm. First of all, you got needless radiation exposure. You've got delayed, absent, or a wrong diagnosis. Yeah, I need to sign that, don't I, guys?
Can I sign for her?
Do you need a sign for it, or just finish?
Oh, yeah, go for it. Thanks, guys. So delayed, absent, or wrong diagnosis, the wrong organ can be removed. And actually, there was a case where a pelvic ultrasound was done, and I'm not going to say where, but the ovaries were mismarked as to left and right, and there was a lesion that actually had to be removed and was on the wrong ovary. And you know, we as radiologists have no way of knowing which ovary is left and right by just looking at the picture. So that's just an example of something that, was a few years ago, but this stuff happens. So we have to be careful. Loss of trust in the hospital and staff. I mean, you don't want to have to go back into the patient room and say, hey, I got good news and bad news. The good news is you don't have pneumonia. Bad news is, now I got to do your ankle. So they're going to be sitting there saying, I don't know if I want to stick around here if these guys don't even know where they're supposed to be taking the x-ray. And of course, the radiologist's not happy, and you know what happens then. It goes downhill. So bottom line, this is a problem that we need to recognize. Don't poo-poo it like I do on occasion. Remind me not to poo-poo it. Take the needed time and care when you're dealing with patients because you want them to adequately put their trust in you. Make the radiologist happy. And last but not least, be sure and improve department morale by tattling on your coworkers that aren't following the rules so that they get in trouble and hate you forever. This goes a long way in improving department morale. Okay, this is actually probably a good spot to take a pause and everybody grab something to eat and we'll pick up. So after our Pizza Hut break, we're going to get back in it. So where we left off is increasing department morale. Got it? Good. Next, we're going to talk about radiation safety. And I'm just going to say that if you see this over the horizon in Lake Winnebago, it's pretty much over. You don't need to worry about anything I'm talking about after that. But this is more likely to be my kid car on the other side of the lake, firing up. So basically, this is the bottom line. Patients want to know, is this going to kill me? Should I be here getting this done? Or you hear the media talking about how radiation is bad for you. I mean, am I going to die as a result of having this thing? Well, what is the dose? Let's try to put it in perspective a little bit. So here's some numbers that I pulled up. I don't have any interventional stuff in here because that's so variable depending on the complexity of the procedure and all that. But so basically a PET scan, about 25 millisieverts of dose. So how does that compare to anything else? Well, each of us gets background radiation every year about 3 millisieverts. So you're talking about 8 years worth of background radiation for a PET scan. And that's all the way down to a hand x-ray that's only about 3 hours worth of background radiation. So there is quite a span of doses, obviously, from the different things that we do. So what's that mean? Well, the risk of cancer death from a radiology procedure, a chest x-ray, roughly about 1 in 1.2 million. CT angio for PE, about 1 in 1,600. And these are really just gross estimates because all of this mortality data related to radiation is based on extrapolated numbers from the atomic bombs back in World War II. And there is so much variability and leeway, and it's really tough to be accurate with this stuff. So there's a lot of guesswork with all of this. So how does that relate to other things that we face? Well, lifetime risk of death of a shark attack, 1 in 3,700,000. And if you spend your whole life in Wisconsin, it's going to be less than that. So you may be feeling a little bit good, a little bit safe that, okay, I'm never going to get bit by a shark when I'm in Lake Winnebago. But look at freezing to death, 1 in 6,000. And I think we can all realize that we're in danger of that on occasion. So, all the way down to heart disease, 1 in 5 chance of death from that. So basically, your job is to try and put things in perspective for the patient, make them realize that the exam is appropriate, reasonable, the chance of harm from it is extremely remote, if any at all. And the flip side of that coin is the fear of radiation can cost lives as well. And I told some of you this story, but I don't know, this might have been half a year ago, 6 months ago or so, but a patient came into one of our facilities and she had noticed this breast lump, and she had been seeing something that she called a spinal manipulator. She told me that it wasn't a chiropractor, so I don't know what exactly that was, but this person referred her to a lymphatic massage specialist to treat her mass that she noticed. So she had been seeing this individual for a period of 6 months, and this thing was continuing to get bigger and bigger and bigger. And at the time, I asked her, well, what was their thought process, watching this thing get bigger and bigger? And said, well, they thought that was a good thing because then when it breaks through the skin, it would all just drain out and be gone, and I'd be great. Well, it was getting so bad that she couldn't sleep at night because the pain got so severe that she finally went in and saw a family doctor. So she was so afraid of radiation that she would only let us do a unilateral MAM. We could only do a MAM on the side that she was having problems. She wouldn't even let us image the other side. So this is the MAM, and obviously there's just this huge fungating mass that's breaking through the skin. So yeah, there's two sides of the coin, but it's in general a lot more dangerous to forego having diagnostic x-rays done for treating stuff. So you don't want to go this route. And I hope that that these practitioners who got their licenses out of cereal boxes will stop doing this kind of stuff. So take-home points, radiation risk is real. How significant, severe, really tough to say. Probably less than people think, but it's really tough to say. We want to be aware of it, keep it as low as possible, and do what we can to calm patients' fears. All right, I want to take just a little bit of a break, and it's here because I want to address a topic that really is getting to crisis proportions in our country. I'm sure you've appreciated this. I mean, radiologists get no respect. Sure, we sit around on gilded thrones and we're able to command technologists and have them at our every beck and call, but in general, we just get no respect. You know why? Because nobody knows what we really do. Well, here's what my grandma thinks I do. She knows I'm a doctor, but I don't know. This is what she pictures when you say that someone's a doctor. So here's what the general public thinks I do. They think I'm an x-ray tech. Valued, important profession for sure, but it's not what I do. Just a little side story here too. When I was in residency training, I don't know, I've been my 3rd year into residency training, my brother-in-law had just started x-ray tech school. And we were at a family get-together, and I was sitting next to Grandma Bertha, and she's acting Glenn, my brother-in-law. So Glenn, how long is it going to take for you to get through this? He goes, oh, Grandma, I just started. It's a 2-year program, so I've got about 2 years left of this stuff. And so he turns to me and says, well, what's taking you so long? Just not as smart as Glenn. So this is what the general public thinks I do. Nobody has any idea what a radiologist is. Okay, let's face it, this is what you guys think I do. Sit around in my golden throne, looking at pictures. You know how it is, you come back from the ICU, just taking a portable chest on the 400-pounder, and it's for PICC line placement, so I'm leaning back in my chair, looking at it and saying, well, I don't know, I don't see the Costa-Frank angle on the left side. Go take another one. And as you're walking out the door, you're thinking, get your butt out of that golden throne and take it yourself. I know what you're thinking. Well, I am going to reveal to you what it is I actually do. Now, if this leaves this room, the whole balance of power in the universe could be altered, and so it's important that we keep it under wraps somewhat. But I'm going to let you in on a secret. This is what I really do. That's right. Why do you think I wear these glasses? If not, my identity would be revealed. Saving lives, stamping out disease. That's what I tell my wife when I leave in the morning. Okay, we're going to go into contrast safety. So, we've all heard this scenario, at least those of us who deal with the CTs. Dr. Knabel's patient's creatinine level is 1.5. They want us to do a CT angio chest. What should we do? And you know that if you talk to 5 different radiologists, you'll probably get 5 different opinions. Why is this? Well, because this whole thing is about as clear as mud. There's been a lot of studies that have been done over time, and this one from Mayo Clinic just 4 years ago looked at just over 40,000 patients. And they did a retrospective study over a 10-year period, and they divided them into 2 groups. And one group had contrast for CT and the other group didn't. And they looked at their creatinine levels after the study to see if anything changed. And there was no statistical difference between the 2 groups of patients, even in patients that had severe renal compromise. So other studies that were also done that support this view, and actually I trained at the Mayo Clinic, and I know when I was there, if a creatinine was below 2, we didn't even think twice about giving another dose, or giving them an initial dose. So there's feelings out there that it's definitely a little bit overblown as far as the risk to the kidneys with this stuff. But then you got this study that's done at University of Michigan. They looked at about half the numbers and used the same methodology, but their study did show an association between contrast and contrast-induced nephropathy. So, I don't know. It's hard to say. There's studies that can go either direction. Take-home point on this stuff is don't bother radiologists with contrast-related questions. You're too busy saving the world. We really don't know what causes contrast-induced nephropathy, so it makes it tough to know exactly what the risks are as far as contrast administration. The fear of it is likely overblown. Each patient needs to be looked at based on their unique situation. If someone's coming in for a chest CT with contrast to follow up pulmonary nodules, well, they don't need to give them contrast. If there's a trauma patient coming in and their pressure's dropping, well, you're going to give them contrast. So everybody's situation is a little bit unique. You have to look at how important it is to have it. But one take-home point that we should all remember is that if they do have some component of compromised renal function and they've got diabetes, those 2 things do actually significantly increase the risk for problems. Okay, also contrast related. Dr. Knick, someone is rolling on the floor, gasping for breath in the CT scanner room. So, is this a reaction to contrast or merely an individual looking for attention? Attention seeker, obviously. Angelina Jolie look-alike. So yeah, obviously this patient's having a pretty severe reaction, so there we go. Dr. Smith, ready to do a shoulder. All right, time to save a life. Most reactions are going to happen within 20 minutes of contrast injection, so keep that in mind if it's a long time after that. Obviously, you want to assess the patient, make sure their airway's open, make sure that they are breathing, make sure that they have a pulse. If they're hoarse, if they're having difficulty getting air, then we'll want to use some epinephrine, give them some oxygen. If just some hives and itching, we can get by with just a little bit of Benadryl and monitor them for a while, make sure that they aren't progressing. Vasovagal, lay them down, get the legs up, give them some oxygen, some fluids, and typically they'll do fine, but keep track of that as well. Mild reactions, they do fine without any treatment, but I really just want to keep track of them. And if the guy's crumping, don't waste time finding me. Call the code. Contrast extravasation. This can be bad. So if this happens, basically stop the injection right away, obviously. Elevate the extremity, put cold compresses on it to try and keep it from getting further into the tissues. We have them hang around for a while, make sure that they aren't developing any symptoms. If the pain worsens, things that we're looking for is decreased pulse, changing color, sensation changes. Sometimes surgery has to get involved. This is a picture of somebody that didn't do well with an extravasation. But yeah, I've been doing this for about 25 years, and I've never seen a serious issue related to extravasations, and I've seen a lot of them. So, in my perspective, it's pretty rare. But I don't know, has anybody seen a bad outcome from an extrav? Yeah. So I mean, I think this stuff is pretty rare, but it can be really bad. All right, moving on to good communication, which equals safety. And this is a picture of me calmly conveying the 6th Holden call result from the nurse practitioner. At least that's what I feel like doing, but I don't. So what does good communication include? Okay, first of all, you guys are the gatekeepers, so you want to make sure that the correct test is ordered. If you see something come across that just isn't making any sense, don't do it. The thing that drives us completely nuts is when something comes across our desk and we say, well, why in the world did you do a with and without chest for pulmonary nodules? And you guys say, well, that's what the nurse practitioner ordered. Never say that. If it doesn't look right, check into it. Ask us, call the department, make sure the right thing's happening. Let us know if you see something that looks really bad. And by that, just as an example, say there's a head CT that you're doing through the ER and there's a huge bleed. Don't just put it in the stack. Call us up, say, hey, take a look at this guy. He's in bad shape. Don't just stick it in the stack. Make sure a patient understands. Sometimes we're going in, counseling patients, talking to them about things that we're seeing, alerting them for how they need to follow up. And we think that we're getting across perfectly, but they may just be glassing over, it may just be going over their head. And you guys are going to be the ones that pick up on it after we leave, that, you know what, they're really not quite getting this. And so, make sure that the communication is appropriate there and they're getting what they're getting. Also, good notes related to the histories. This is important. And by that I mean, with a CT of the abdomen, there's a big difference between pain as one history, as opposed to patient has a history of Crohn's disease, has had 2 feet of bowel resected, and has stool draining out of a hole in their abdomen. So we're thinking fistula. That helps us quite a bit. And there is a big variation. And the flip side of that is, don't give us their life story in the notes section. We don't need to know that grandma was walking to the market and saw a penny on the ground and leaned over and lost her balance and trauma. Trauma for that is good. Left hip pain after trauma. Use your judgment. So civility, refer to the picture that I showed first. Try to keep that in mind. Sometimes it's hard. Sometimes you've had all kinds of things happen left and right, and then whoever it is that's you're dealing with at that moment is getting on the last nerve that you have. But something we need to keep in mind. And then make sure that you encourage the clinician to request the study to be a Holden call, because we all love those. Dr. Knable, sir, just told us that to sign off on your reports today, you're going to have to yell, sign, in the mic, spin around in your chair once, do 3 somersaults, and scream like a chicken. Now, this is a little bit of an exaggeration, but not much. But yeah, remember civility. When this happens, this is what I need to remember to do. I may not feel like it, and you may have to remind me too. Put the smile on the face. Okay, MRI safety. I'm sure all of you have noticed these signs that are around the department, Zone 1, Zone 2, Zone 3. It wasn't until I was actually putting this talk together that I noticed those signs. I'm like, you know what, I actually have no idea what those signs even mean. I've seen them for several years, but I've got no clue. So basically, we are right now in Zone 1. We're not in the region of the magnet. Zone 2 is a reception patient holding. Zone 3, the nerve center, that's the control room, and zone 4 is in the room with the magnet. Twilight zone, most of our departments, as you well know. Well, what happens when you're in zone 4 and you should be? The picture on the left is a crash cart coming in to urgently help somebody who's having troubles in the scanner, and they did not help. And on the right, I don't know, some sort of a chair contraption. I'm assuming that somebody climbed in there after the chair got sucked in. At least I hope that's what happened. Can't say for sure. So here's one on the left. I'm sure you recognize a wheelchair that's crumpled up and sucked in the middle of the magnet. Anybody for a grumpy mood bar, who knows what's sucked into the scanner on the right? And you can't be somebody who's heard the talk before or was at the symposium. Jen, you're excluded from it. Anybody have any idea what that is on the right side?
Commode.
Good guess, but no, did you say commode?
Mm-hmm.
No? It's got an electrical cord. Am I gonna have to eat this candy bar myself? A vacuum, that's closer. Yes! Kim wins the grumpy candy bar. Yeah, it's actually a floor waxer. Somebody went into the magnet room doing the floors. Woo! The thing just whipped away, sucked into the magnet. You do not want to be making that call to the housekeeping supervisor. We're going to need a new floor waxer and a new magnet. Okay, now, you got to try and stop idiots from doing stupid things. Kyle was attempting to stop the fool trying to bring in a metal pole into the magnet room. Sadly, he was unsuccessful. Somehow, the idiot managed to squirm out from underneath using nothing but brute strength, and then went straight to have a male mammogram after that. That thing can kill you. It's tough to find statistics on this, but there's a few things, and you might have noticed this a few months ago. There was a man in India who was killed, and the headline in the story said, "Indian man killed after being sucked into MRI machine." And when I read that, I thought, no, that's not right. What? So in reading the story, what actually happened was somebody walked in with an oxygen canister and sailed through the air and crushed the guy and killed him. In 2001, there's also a documented case of a 6-year-old kid who was getting a scan, and someone walked in with an oxygen tank, flew in there and crushed his skull. You do not want to be the person walking into the room with something bad that hurt somebody. I mean, that's tough to live with for the rest of your life. So, there was another person that was killed from a dislodged aneurysm clip. He actually thought he had a different kind of a clip, but he was mistaken, and the thing dislodged, and he ended up dying. So it's tough to find statistics. I actually could not find that many deaths related to the magnet, but there was a story in, well, not a story, but when I was talking to Tony, actually, when I was working this talk up, he was telling me that they were bringing an ICU patient in to do a scan, and the ICU nurse came in, and he had scissors in the lab coat, and walks in, and the scissors, when he gets close to the magnet, just goes right up to the magnet, and you know, they got it off of there. Nobody was injured. But this stuff happens on not an infrequent basis. And we definitely need to take precautions with this because bad things can happen. So I'm going to hit you with a few true or false questions just to test your MR savviness. Now, you don't have to worry about a magnet. Just be careful not to turn it on until you know it's safe in the room. False, right? The magnet is always on. It is not ever off. You can trust a 12-year-old telling you he doesn't have a history of eye injury. Yeah, that's false too. Actually, there was a story of this 12-year-old kid who was being brought in to get a scan, and as he got closer to the magnet, he was complaining, pain in my eye, ow, ow, ow. So they take him out of the room and get an x-ray, and he had pulled a Ralphie, got a BB in his eye, and it was, you know, moving as he was getting closer to the magnet. Fortunately, he wasn't blinded by that, but yeah, it's, you know, it's really kind of a tough deal too, because we're not x-raying all these kids, so, you know, what do? Be careful as you're taking them in the room. Okay, next one. You may want to avoid rolling the patient into the magnet room in their wheelchair. through. A pacemaker is no problem, come on in. Trick question. Some pacers are MR safe, but actually most of them are not. But you gotta know which ones you're dealing with. Huge book to look through and make sure that you know which ones can and can't go in there. An aneurysm clip is an absolute no-no in the magnet. No, not true. Obviously the old ones are no-nos, but the newer stuff is actually MR safe. So the best thing to do is get the op report and see specifically what was used, look it up in the book and make sure that this is something that's safe to go in. The tattoo on my butt was getting hot in the scanner. Am I nuts?
No.
Well, if you have a tattoo on your butt, you may be nuts. I don't know, just show of hands. How many people have tattoos on their butts? Just Bill. Yeah. No, actually that is true. There can be some ferrous ions in the ink, and that can cause kind of a heated up rash when you go in the magnet, so patients might notice something when they're going in there.
All right.
Hey, I didn't do it. All right, take home points. Obviously never, ever, ever bring unsafe metal into the magnet. Don't cut corners when you're screening patients. Be cautious when people are coming in there that you know aren't typically in there. Make sure that they don't have anything on them. Watch as you're bringing patients in there. If there's any unusual signs or symptoms, take it seriously and take them back out. Do not ask me for a ride in my supercar. All right, any deep probing questions that show how smart you are? Any stupid questions? Well, I appreciate your time and attention. I would like to hang out and talk with you more, but
I got it.